Okay. Hello, everyone. My name is Lizzy Simmons, and I'm a third-year doctoral student in the Department of Maternal and Child Health at UNC. And today, I'd like to talk about strategies to improve preeclampsia care for women in North Carolina. And to do this, I'll start by telling a brief story of my friend, with her permission, whom I'll refer to as Betty. Earlier this year, Betty was about 27 weeks into her first pregnancy when she attended a routine antenatal care visit and was diagnosed with preeclampsia, which is a pregnancy condition characterized by elevated blood pressure in women with previously normal blood pressure and can be very dangerous for both mothers and babies. Betty was immediately hospitalized, and when after a week her doctors couldn't manage her blood pressure, she underwent an emergency cesarean section. Her daughter, whom I'll refer to as Erin, was born at 28 weeks. Since Erin was born so premature, she was admitted to the NICU, where she stayed for 2 months before being able to go home. Fortunately, Betty and Erin are both fine now, as they both received the care that all pregnant women in North Carolina deserve, but so many don't receive due to the many barriers in our healthcare system. I'd like to highlight what I think are 3 interventions to improve equity in care for women with preeclampsia in North Carolina. The first is Medicaid expansion, which, although is a politically heated topic, would give many more adults in North Carolina access to health insurance. Preconception health insurance can lead to earlier initiation of prenatal care, not only allowing for earlier diagnosis of preeclampsia, like in Betty's case, but also giving more women access to methods to prevent preeclampsia earlier in pregnancy. The second intervention is patient safety bundles, which can be implemented at the health facility level to standardize processes to diagnose and treat preeclampsia. While Betty didn't encounter any resistance to recognition of her symptoms from her physicians, providers are more likely to disregard complaints of discomfort or pain by non-Hispanic Black patients, leading to many misdiagnoses in this population. The final intervention, while less health-related, is particularly important for women with pregnancy complications or parents with infants in the NICU, and this is paid parental leave. Betty and her husband were both fortunate in that they had paid leave so they could be with Erin in the NICU, but this is not the case for so many parents. While there are many more interventions we could consider, I think a combination of these 3 will improve equity in preeclampsia care for women in North Carolina and lead to more women having outcomes similar to that of Betty and Erin. Thank you.